Thanks very much, Carlo. So, Carlo's right. I have known him, I think, since the early 2000s. And one day he'll remember I'm in Glasgow, not Edinburgh. Anyway. So, I mean, I have to say it's a great pleasure to be with you today. This isn't the kind of talks that we do normally. And so it is an honour to be invited, and I'm grateful to Carlo and Make Seconds Count for the invitation. And I really do hope some of this is useful for you, and I think we'll have plenty of time for questions and discussion at the end. So I'm going to speak specifically now about HER2 positive secondary breast cancer. And this slide shows my disclosure, so I have undertaken some paid advisory work for the pharma companies shown. Now, this is what I intend to cover. So firstly, what do we mean by HER2 positive? What makes a breast cancer HER2 positive? How do we define this? How do we test for this? Then secondly, how can we use this information to target HER2 specifically with drugs? We'll then come on to how HER2 positive secondary breast cancer is treated today in 2025, and then finish with just maybe a little bit of what's changing and what might be coming. So firstly then, what makes a breast cancer HER2 positive? And firstly, what is HER2 itself? So just to get right back to basics. So HER2 is a protein, and it's found on the surface of cancer cells. And HER2 doesn't exist on its own. It's actually a member of a family. So you've all heard of HER2. There's also a HER1, a HER3, and a HER4. And these are all closely related proteins. And the diagram on the left shows whereabout we find them in the cell. So all this picture is showing is the edge of a cell. The top of the picture is the outside. There's then a thing called the cell membrane, which is the edge of the cell. And then the bottom, sorry, these are just moving on automatically, I don't know why. Inside the cell is the nucleus, and HER2 is shown there in purple. The other family members are there. And the important thing is that this protein kind of straddles that cell membrane. So part of it is outside the cell, part of it crosses the membrane, and then part of it is inside the cell. And together with its partners, its normal function, because you find HER2 not just in breast cancer cells, but in a whole load of normal cells. So usually what it does is transmit information, chemical signals from the outside of the cell to the inside. And this is important for the way organs develop, like the heart, for example, and helps many types of cells coordinate how they grow, divide, and repair themselves. So not just in breast cells. And as I said, the function is to transmit information or signals. HER2 does this by partnering up with one of the other family members. And then the kinase domain, so that's the part inside the cell, shown at the bottom, that sort of rectangle, it fires additional chemical signals down into the middle of the cell to the nucleus, and that makes the cell change its behavior. And when this becomes out of control, not properly regulated, this is what drives the aggressive behavior of a breast cancer cell. So what is the underlying problem here? What happens to make a breast cancer develop as the HER2 positive type? So the initial problem is some form of damage to DNA in a cell, some form of instability. And this results in there being too many copies of the HER2 gene. The HER2 gene gets replicated. So instead of there being just a single copy on chromosome 17, there can be lots of copies inside a cell. And we call this amplification. All amplification means is too many copies. That's just the technical term that we tend to use. Now, when there are too many copies of the gene, again, they're not properly controlled. There's too many of them, so they churn out lots of HER2 protein. And all of that protein goes up to the surface of the cell where it sits there. And you can see this in the pictures on the right-hand side. So again, that's a normal cell at the top. You can see the cell membrane. That's HER2 sitting there in the membrane, and there's a few of these molecules dotted about doing what they're meant to do. On the bottom is a HER2 amplified cell, and there you can see, instead of there being a few copies, well, in reality there can be tens of thousands of copies of the protein, all of them firing these signals into the nucleus, telling the cell to grow and divide and move around. So this is the underlying abnormality, too many copies of the gene making too much HER2 protein. Okay, so how do I, as an oncologist, know if a particular cancer is HER2 positive or negative? And here we need to rely on our colleagues in pathology. So what they will do is take a very thin slice from a biopsy, and they will then put it on a microscope slide, and they will put a special stain on it that makes HER2 show up as brown. So hopefully this presents just about well enough. If you look at the far right-hand side, there's quite a lot of brown staining there. It's a kind of cobblestone appearance because we're staining the protein at the edge of the cancer cells. And that is what we would call 3+. So we grade how much brown there is: 0, 1+, 2+, or 3+. 3+ is the strongest, and that is a HER2 positive cancer. At the other extreme, we could have what we call IHC, or immunohistochemistry 0. There's no staining at all, and that's HER2 negative. Doesn't actually mean there's no HER2 there. There will be a little bit, as in normal cells, but the stain is designed only to pick up excess levels, not the normal amount. And so that would be IHC 0, clearly HER2 negative. We might have just a little bit of staining, and we call that 1+. They're HER2 negative. Nowadays, they would fit into a category that we call HER2 low, which is different to the HER2 positive breast cancer that we're talking about today. And that leaves more borderline cases that we call 2+, where there's a moderate amount of staining. And with cancers like that, some of them will be truly HER2 positive, but some of them will be HER2 negative. And then the pathologist needs to go on and do a second type of test. And this is called in situ hybridization, ISH, or FISH. You might see these terms in your pathology report. And what this does now is, instead of looking at the protein, the pathologist actually counts how many copies of the HER2 gene are actually in the cancer cells. And this is a little bit more time consuming. And this is shown on the left. So what the pathologist does is put a tiny little probe on that can stick to the HER2 gene. And in this example, that's colored red. And they also have a green one that sticks to chromosome 17, where the gene normally is. And in a completely healthy situation, you would have the same number of green dots and red dots. It would be 2 per cell. We've got 2 chromosome 17s. But what the pathologist is looking for is when there are many more red dots than green dots. So that means that there are excess copies of the HER2 gene. It's HER2 amplified, and that's what's shown here. And in that case, that would also be a HER2 positive cancer. So if you were ever to see your own pathology results, they may either say IHC 3+, or in some cases might say IHC 2+, FISH positive. In both cases, that takes us to a HER2 positive cancer. So having done this then, made the diagnosis, what proportion of breast cancers are HER2 positive? And these are data from Scotland, actually, for all breast cancers. This is primary and secondary breast cancer, but about 15% of all breast cancer will be HER2 positive breast cancer. And within that, about 2/3 of the 15% will also be estrogen receptor positive, and about 1/3 will be estrogen receptor negative. And in the past, we haven't maybe paid quite as much attention to estrogen receptor in the context of HER2 positive cancers. We've tended to somewhat lump them together. But increasingly, I think treatment pathways will maybe start to diverge according to whether a cancer is HER2 positive, ER positive, or HER2 positive, ER negative. So another common question then is, do we need to test a secondary site? Do we need to biopsy a metastasis, or can we rely on the primary cancer? And, you know, I think the kind of textbook answer to this is yes, in general, it is a good idea to biopsy a secondary site. We're making big decisions. We need to get the best information we can. And the reason for this is most of the time, if you look at the primary tumour, if you look at a secondary site, the receptors will be the same. 9 times out of 10, let's say, they'll be the same. But maybe 1 time in every 10, they will be different. And if we think about how a patient can be diagnosed with secondary breast cancer, this can happen in 2 ways. A minority now probably will be diagnosed with what we think of as recurrent secondary breast cancer, so shown at the top here. So these are people who have had a primary breast cancer diagnosed. They have probably had treatment given with the aim of preventing recurrence, but ultimately that treatment has failed the patient. And unfortunately, the cancer has recurred maybe months or years later. This is recurrent breast cancer. The other group, and probably slightly larger group, is what we refer to as de novo secondary breast cancer. And this is when the metastases are diagnosed at the same time as the primary cancer. So for example, a woman may present with a breast lump, have a primary cancer diagnosed, but have a CT scan performed, and that already finds overt metastases, and this would be de novo. Now, the reason I make a discrimination here is that in the context of a de novo diagnosis, it's actually far less likely to find discordance between the primary tumour and a metastatic site. But particularly in cases of recurrent secondary breast cancer, where treatment's been given, where time has passed, then I think there's an even stronger argument for trying to biopsy a site where that's safe and feasible to do. And we can find, in some cases, gain of HER2. So somebody could start off with a estrogen receptor positive, HER2 negative cancer, and then at the time of recurrence, it's estrogen receptor positive, HER2 positive, particularly with very early recurrences. And on the flip side, we can have situations where someone starts off with a HER2 positive primary breast cancer, but then the recurrence has become HER2 negative. Now, I think this is important information to have, but we also have to acknowledge that it can then create some difficult decisions. These are some guidelines from a few years ago, and they would suggest that where the results of things like HER2 estrogen receptor differ in a metastatic lesion from the primary tumour, we actually don't have strong evidence on which of the results to go with. And so it involves taking a step back, looking at exactly what treatment's been given, what is the clinical behaviour, what did the original biopsy look like, maybe we want to biopsy another metastatic site even. And accepting often evidence is then unclear what the best option is. At least with that information, the oncologist can have a discussion about what they think should be suggested and the reasons for that particular course of action, accepting that's not always entirely evidence-based. Okay, so how can we target HER2 with drugs? And I'll take you right back to the original scientific publication. So 1987, this was Dennis Slayman's famous publication, and HER2 had only recently been identified. This was a time in the early 80s when lots of the genes and proteins linked to cancer were discovered for the first time. And in this publication, what his group did was identify for the first time that there was a group of patients with breast cancer characterized by amplification of this gene, so HER2 positive, and at that point at least, that this tended to go with a very aggressive course of the cancer. And at the end of that paper, he wrote, if the HER2 gene does play a role in the pathogenesis of breast cancer, because that wasn't really known, then the development of specific antagonists or drugs could have important therapeutic implications. And that's exactly what we've seen happen over the intervening decades. So the first way that HER2 was targeted was with a monoclonal antibody, trastuzumab, also known as Herceptin. And a monoclonal antibody, so essentially this is just like the antibodies our bodies produce normally to fight viruses, to fight bacteria. This has been engineered or selected to specifically to recognize part of the HER2 protein. So again, what you're looking at here, that's the cell membrane, there's the inside bit, and there's the outside bit. And the antibody can come and stick onto the outside bit of HER2. And then more recently, a second antibody called pertuzumab, also known as Perjeta, came along. And nowadays, quite often, we would give the two of these mixed together as an injection given under the skin in the thigh, and that's what's known as Phesgo. So how do these antibody drugs work? Well, they probably have a few different ways of attacking HER2-positive cells, but with trastuzumab, we think the main one is it does really what antibodies are meant to do. It sticks onto the protein and encourages immune cells to come and attack the cancer, and particularly a type of immune cell called a natural killer cell. Pertuzumab seems to work in a different way, so it also sticks onto the outside part of Herceptin, but it sticks onto the bit that is specifically involved in letting HER2 join up with the other family members, particularly the one called HER3. And it sticks onto that bit and basically just physically gets in the way, so HER3 can't partner up with HER2. And the HER2-3 partnership is a very strong source of these chemical signals into the cell, so this disrupts that. And it turns out that the two of these antibodies tend to work best when given together, at least when we're talking about initial treatments. And that leads us on to the next class of drug known as antibody-drug conjugates. And they're based on the same monoclonal antibodies, but now with a very potent molecule of chemotherapy stuck directly onto that antibody. And these are the drugs trastuzumab emtansine, also known as TDM1 or Kadcyla, and trastuzumab deruxtecan, which is TDXD or Enhertu. Now, don't worry about the details of this whatsoever. This is purely to show that all of these drugs are made up of three parts. So firstly, an antibody, and this is just the same trastuzumab, the same Herceptin that we were already talking about, but stuck onto it is this molecule of chemotherapy. It's called DM1. And then there's a chemical linker just to attach that chemotherapy. Now this picture's a little bit misleading. It makes it look like there's one molecule of chemotherapy stuck onto the antibody. In fact, there's about 3 or 4 on average stuck to each molecule of trastuzumab. Now the idea behind this is that that TDM1 can then come along, stick to the bit of Herceptin that's outside the cell, and that's what's shown here. So you have the cell membrane again, that's meant to be Herceptin. There's TDM1 coming and sticking onto it. And when that happens, a natural response of the cell is then to internalize the antibody with the TDM1 stuck on. And so that comes into the middle of the cell to a part called the lysosome. The lysosome breaks down protein, so it breaks down that linker and it releases the chemotherapy. You can see that there right into the middle of the cell. So the idea here is you're taking very powerful chemotherapy but delivering it specifically to the cancer cell. So it's far less chemotherapy than a standard chemotherapy infusion. And then this is the second drug Enhertu. Again, the details of that diagram don't matter. It's just to show that there's the same antibody, trastuzumab, with a linker and chemotherapy. This time it's called deruxtecan. And with this drug, there's actually 8 molecules of chemotherapy stuck onto each antibody. The linker is not quite as strong as TDM1, so a little bit more of this drug gets released into the circulation after infusion. And another difference is that the deruxtecan, unlike the DM1, when it's released inside the cell, so exactly the same thing happens, it's internalized, goes to the lysosome, the chemotherapy is released and it can act on that cancer cell, but it can also leak out. It can get over that cell membrane and go and affect other cancer cells in the vicinity, some of whom might not have as much HER2 on the surface. And it turns out these differences make this a more powerful drug. It's more potent than TDM1, but that comes at the cost of more side effects. And in particular, this is much more like chemotherapy than TDM1 in terms of the side effects. And then the final way that we target HER2 is now moving away from the part outside the cell, but instead coming into that kinase domain. So this is the part inside the cell that then fires off these signals down to the nucleus. And we can block how that domain works with what we call small molecule drugs, things that are big enough just to go inside the cell. And these are drugs like, well, primarily tucatinib is the one that you'd be most likely to come across. Okay, so using these different drugs then, how would we try and treat HER2 positive secondary breast cancer today in 2025? And what I'm going to do is just try and build up a generic pathway here. This is probably the sort of treatment oncologists would suggest to most patients most of the time. By no means is this how every patient is treated. This audience doesn't need me to say that every patient is different, but of course there are all sorts of reasons that a particular drug may or may not be used at any moment in time. But this is a sort of fairly generic overview. So we've already said that for most patients with HER2 positive secondary breast cancer, they will be diagnosed either with this de novo metastatic disease, or they may have had primary breast cancer, adjuvant, neoadjuvant treatment, and relapsed later. And if that's at least 6 months to a year, then this is the pathway we would follow. And that would usually be to start off with a combination of chemotherapy, trastuzumab, and pertuzumab. And that chemotherapy most usually would be a type of drug called a taxane. That means docetaxel or paclitaxel. Docetaxel is probably the commonest, so this is treatment given intravenously once every 3 weeks. And we would tend to keep that chemotherapy going, not usually indefinitely, but usually for a defined period of time, perhaps 6 cycles, 18 weeks. The reason being there is limited benefit in going beyond that, and because cumulative side effects do start to build up. But at the point the chemotherapy stops, we keep going with the monoclonal antibodies every 3 weeks. And for the 2/3 of patients who are also whose cancers are estrogen receptor positive, we would also add in a hormonal drug at that point. And then the big unknown is how long the benefits of that first-line treatment will last, because there is a huge variation in possible outcomes, from the worst case, which is the treatment doesn't even work at all, or the benefits are very short, through to the best case, which is a patient who has 18 weeks of chemotherapy, goes on to monoclonal antibody therapy, and a decade later, they're still coming every 3 weeks for their Herceptin. And unfortunately, that's a minority of patients, but that's the range of possibilities that can happen. But for most people, at some point, the cancer then somehow finds a way around this treatment. Then we need to think about what treatment would be given next. And as of really very recently, that would usually be with a drug called trastuzumab deruxtecan. So this is in HER2, antibody drug conjugate. Until recently, it would more commonly have been TDM1, which was the first generation drug. Then trastuzumab deruxtecan came along and was shown to, as I said, it's more potent, it will control the cancer for longer. And that for most patients is what we would then use as our second treatment. And for the relatively smaller group of patients who have had primary breast cancer, adjuvant, neoadjuvant treatment, and whose cancer has unfortunately reappeared very early, within 6 months, this is the point that they would feed into the pathway. So we wouldn't go back to that taxane, trastuzumab, pertuzumab with such a short interval of time. And again, as for how long trastuzumab deruxtecan would control the cancer, it's highly variable. But unfortunately, usually at some point, the cancer again starts to find a way around that treatment. We then move on to third and fourth line options. And here we would still use TDM1. We would also use a combination of tucatinib. So this is what a tyrosine kinase inhibitor, which is given along with trastuzumab and capecitabine. And it is likely that most patients would receive one or another in either order. Once we get beyond that into maybe the fifth different type of treatment we're recommending, then I think things really do become less standard. And there are various chemotherapy options that we may speak about, that may be with or without trastuzumab. So that's a fairly sort of generic pathway, but I think quite representative of how many people would experience treatment if they were diagnosed in 2025. So I'll just finish off then more briefly with what's coming. And actually, this potentially is a vast topic, so I think what I've decided to do is just present a couple of very recent studies, because you may or may not be aware of them. They have had a bit of publicity, and then finish off just more generally with some things perhaps a little bit further away. And so the first clinical trial that I'll mention is one called Destiny Breast 09. And this was presented for the first time at a scientific meeting in Chicago just a couple of weeks ago. And this has really sparked a lot of interest and discussion. And what this trial was doing was looking to see, well, we've already shown that giving trastuzumab deruxtecan is kind of better than TDM1, so it's moved up to second line. Could it actually be the best treatment to start with? Is it better than our standard now of taxane, trastuzumab, and pertuzumab? And so people who volunteered for this trial had newly diagnosed breast cancer. Half of them received the standard taxane, trastuzumab, pertuzumab, and half of them went on to receive trastuzumab deruxtecan. That was also given with pertuzumab. And the results of that trial did show that trastuzumab deruxtecan seemed to be better. So, for example, if we look at the proportion of patients whose cancer was still fully under control at 2 years, about 70 of every 100 patients had controlled cancers when treated with trastuzumab deruxtecan, compared to about 52 of every 100 treated with the standard treatment. So, seems to be a more powerful treatment. So far, so good. That would suggest let's move that to our first line. I think I'll just use this to highlight one of the problems and difficulties, though, when we try and improve treatments in breast cancer, and that is that our clinical trials often focus on a specific moment on time. They don't look at the whole pathway that a patient's going to experience. This trial tried to a little bit, but not properly, you could argue. And the problem is that actually TDXD, I would say, has for most people got more side effects actually than chemotherapy. It's a fancy new targeted treatment, but actually it has significant side effects. It has some life-threatening side effects in a very small minority of people. And therefore, is it really the best treatment up front for every single person? Given I've already said there are some people have the standard treatment and it then works for a very long time just with a 3-weekly antibody injection. That still has side effects, but not of the level trastuzumab deruxtecan. So, the real question is actually who needs it as the first treatment? Who is that really, really the best thing? Are there some people actually who would do just as well if we gave it, but not as the first treatment, potentially as a backup second treatment? And these are things that to this day we're actually not very good at answering, and the type of trials we do often don't interrogate that properly. Now that's not to talk down the result. Oncologists were very excited by this. This will become, I think, a standard for some people. It's just to try and say we always need to try and think more holistically. And then a second trial called Patina. This was presented about 6 months ago at the other big breast cancer meeting called San Antonio that you might hear about, where, again, a lot of the most exciting results are presented. This was another clinical trial, and this was for these group of patients who'd started off treatment, finished the chemo, they were on the antibody drugs and had the hormonal type of cancer where we give endocrine therapy. And this was asking whether adding another drug at that point, called a CDK4/6 inhibitor, would be useful. And CDK4/6 inhibitors we use routinely in patients with the more common type of breast cancer, hormone receptor positive, HER2 negative, and we know they make a big difference. And they have been relatively understudied in HER2 positive, ER positive breast cancer. And it turns out actually that adding in this drug is of benefit. So again, to look at the trial results, using just this arbitrary figure, how many patients had their cancer controlled at 2 years, well, that was 65 out of every 100 patients in the group who received the palbociclib versus 55 out of every 100 who didn't. So again, this is potentially a meaningful benefit, at least for some patients. And I think the broader point here is I think this result forces us actually to rethink some of our assumptions and to go back and look at all the drugs used in ER-positive breast cancer and get back to seeing really whether they can have similar benefits in HER2-positive breast cancer along with effective HER2 blocking antibody therapy. So this is just the very last slide. I've probably gone over a little bit. I apologise. This is a very busy slide. I won't go through everything, but it's just to show the range of activity that is ongoing. This includes immunotherapy. Now, results with immunotherapy to date have been quite disappointing in HER2-positive breast cancer. That's not to say there will be no role. I think we just need to understand why previous attempts maybe have not worked and who the group of patients are where this could be beneficial, and potentially using newer and better types of immunotherapy. There are new anti-HER2 monoclonal antibodies coming along, new antibody drug conjugates, new antibodies called bispecific antibodies that are fundamentally different to what's gone before. And there are antibodies targeting HER3 and HER3 antibody drug conjugates. As I mentioned, there are various drugs we tend to think of more in the ER-positive type of breast cancer, and there has long been an interest in vaccines for HER2-positive breast cancer. Again, the results have been really disappointing so far, but as you probably know, there are new vaccine technologies coming along, and this is ripe to be revisited.